Good afternoon or good morning, depending on where you are. It's my pleasure to welcome you to the 9th annual Philip R. Nader Legacy of Health Lectureship. My name is Deanna Helsher, and I am the Regional Dean of the UT Health Houston School of Public Health in Austin. Next slide. I'm also the founding director of the Michael and Susan Dell Center for Healthy Living, which has a vision of healthy children in a healthy world and a mission to advance health and healthy living for children and families through the research that we do, innovative community-based programs, and dissemination of other evidence-based practices. Next slide. So we have a lot of center resources for you. They include regular webinars, bi-monthly newsletters, blogs by and for experts, extensive child health resources, and the Texas Child Health Status Reports and Toolkits. Please scan the QR code on your screen to visit our website and explore these resources. In addition to the previous resources, our center leads the Texas Research to Policy Collaboration, or Texas RPC project, which creates legislative-related resources described on this slide. You can scan the QR code to learn more here as well. Next slide. We also have data on Texas kids, lots of data on Texas kids from 2021-23. So these are from the Texas School Physical Activity and Nutrition Survey, or Texas SPAN. It's a state Texas-wide surveillance system that monitors trends in body size in school children and other obesity-related factors. The new 2021-23 data will be coming out soon, and the QR code here takes you to our SPAN Data Explorer. Next slide. So we're really, go back one slide, please. Yeah. We're really excited today to talk about food as medicine. And we know that culinary medicine bridges the gap between nutritional science and the art of cooking. By combining evidence-based dietary guidance with practical culinary skills, this emerging field aims to improve health outcomes. And you'll hear a lot more about this later. But I just wanted to highlight one of our recent projects, which is Food is the Best Medicine, which delivers weekly food boxes to postpartum moms for 8 weeks. And it's really been well received and has some nice initial outcomes. So you can use the QR code to find out more about that. And with that, if we can go to the next slide, I would like to talk a little bit about the Srila and Vibhu Sharma Endowment for Excellence in Community Health, Climate Health, and Sustainability. This provides pre-doctoral students with a stipend each semester so that they can do research in these critical areas of nutrition, climate health, and sustainability research. We really acknowledge the Sharma family, and Dr. Sharma is here with us, for their commitment to public health nutrition and the School of Public Health. This really has been a fabulous initiative. So I am happy to announce our newest 2024 Sharma Fellow is Rebecca Jayawo. Jayawo in the Department of Health Promotion and Behavioral Sciences is going to be leveraging this fellowship to further research in community nutrition. Her research interests focus on preventing and managing diet-related chronic diseases, and these include hypertension and type 2 diabetes, especially among underserved communities, including people of African descent. Growing up in Ghana, she witnessed firsthand her mother's struggle with hypertension and chronic kidney disease, which ultimately led to her passing. Through her research with the fellowship, she hopes to deepen her research skills and gain hands-on experience conducting studies that can directly impact health outcomes. Rebecca will have the opportunity to work with Brighter Bites, which is a nonprofit organization that aims to improve health eating behavior by providing routine distribution of fresh produce along with corresponding education in school and at home. And Dr. Sharma is a co-developer of that program, a co-creator of that program. A research commitment of 2 semesters and participation in research really includes collecting data and writing manuscripts and publishing. So really a fabulous experience, as I mentioned before. Since 2017, we've had 9 Sharma Fellows who've gone on to use their experience to better public health nutrition. So I'd like to hand it over right now to Dr. Shrila Sharma, who will introduce our speaker for today.
Thank you so much, Dr. Halsher. I'm Shrila Sharma. I'm a professor of epidemiology and director of Center for Health Equity and faculty member of the Michael and Susan Dell Center for Healthy Living. Next slide, please. Thank you. Before we start our keynote today, I would like to talk for a minute about Dr. Phil Nader's legacy, since he is the reason we are all here today for the annual lectureship. The Nader Legacy of Health Lectureship is designed to educate and inform academics, providers, public health students, and community members about primary prevention and community pediatrics. Today, we are fortunate to learn from and be inspired by Dr. Kofi Essel of Elevance Health. The goal of this lectureship is to stimulate collaboration that moves us forward to improve health status for parents and children and families, a legacy of health for generations to come. We are so grateful for Dr. Nader's leadership and his incredible contributions to this work. And we want to thank the Nader Endowment for funding this event. Next slide, please. Additional staff support for today's event and keynote presentation webinar is provided by the Michael and Susan Dell Foundation, so we also want to thank the foundation for their support. Next slide. So it is now my pleasure to introduce this year's keynote speaker, Dr. Kofi Essel. Kofi Essel is the inaugural Food is Medicine Program Director at Elevance Health. As a core member of the Health Outcomes Organization team, he continues to work to coordinate with broader social impact strategy, health equity, and medical policy initiatives throughout the enterprise. He leads efforts in designing innovative approaches to address diet-related chronic diseases and social risk using novel food interventions. Dr. Essel is a board-certified community pediatrician at Children's National Hospital and clinical associate professor of pediatrics at the George Washington University School of Medicine and Health Sciences in Washington, D.C., most recently serving as the director of GWU Culinary Medicine Program. Dr. Essel has dedicated his career to advocacy and research around healthcare and public health workforce training, health disparities, and community engagement with expertise and national recognition in the areas of addressing diet-related chronic disease and food insecurity with patients and families. Dr. Essel sits on the National Academies of Sciences, Engineering, and Medicine's Roundtable on Obesity Solutions Lived Experience Innovation Collaborative and was nationally recognized by the Alliance for a Healthier Generation for helping to create an innovative curriculum to enhance pediatric resident training skills on nutrition-related disease management. Dr. Essel sits on the board of directors for the Food Research and Action Center, or FRAC, and serves as a physician advisor for the Partnership for a Healthier America's Veggies Early and Often campaign. Dr. Essel is member of the executive committee for the American Academy of Pediatrics section on obesity. He also co-authored a national toolkit for pediatric providers to address food insecurity in their clinical settings with the American Academy of Pediatrics and FRAC. Dr. Essel earned a BS from Emory University with a focus on human biology and anthropology and earned his MD and MPH in epidemiology from GWU. So with that, I'll hand it over to Dr. Essel to begin the keynote presentation.
Right. I'm going to share my screen and I would love to get started. I am honored to be here today. When I was told about this opportunity, and informed about it. I was amazed that you all would select me for this. I want to thank the selection committee. I want to thank Dr. Helsher, Dr. Sharma for their thought leadership, for inviting me down. I want to thank some of my good friends in the area as well, Rupa and Jacqueline and Wes. I want to thank some of my other colleagues who are down in the Houston area as well. This is just really an honor to be able to celebrate the legacy of Dr. Nader. Today, what I would love to do is really dive into this concept of food as medicine, really give you a sense of understanding this whole sort of momentum around this movement. And I'm sure you all are quite familiar with this momentum. But as a whole, typically the conversation of food as medicine doesn't really focus on pediatrics, on children. And so for today, my hope is that I can charge you all, encourage you all, activate you all to be an advocate, to be a voice for the next generation. I think that this concept of focusing on children should be something that we maybe should consider more often. So our title for today's conversation is Food as Medicine in Pediatrics, a Necessary Responsibility. Without further ado, let me get started so we can save some time for Q&A at the end. So first and foremost, I have nothing to disclose. I have 3 things that I want to make sure you all leave here today with. So my 3 learning objectives, like any good academic would highlight, is number 1, I want to describe the growing movement of food as medicine in healthcare. Number 2, I want you all to see what are the gaps around food as medicine. What things should we sort of be filling in this space? And last but not least, number 3, I want you to sort of be able to describe some practical examples of how you can incorporate food as medicine in pediatric clinical settings. Now, to get started, I love telling stories. And one of the stories I would love to tell you about is someone who's meant a lot to me in my life. And I took this picture a few years ago with this matriarch in my family. And this is my grandmother. My grandmother, I always attribute to teaching me the very essence of food as medicine. My grandmother taught me how to cook. My grandmother, I saw how she used food as a tool to bring our family together, to put joy on the faces of my family, of my friends. I saw how she used food as a tool of togetherness. And not only that, I saw how she used food to improve our health. This was sort of the foundations of my understanding of food as medicine. And I think it's critically important to understand the multitude of layers in which food can play in one's life if you're going to have this conversation around food as medicine. Later on, I was very interested in the food culture and how food influenced society. And so in college, I studied biology and anthropology at Emory University. And I got a chance to study different cultures around the world and how food was used as a tool for health, for joy, for happiness, for peace. This was one of the things that really drew my attention. So years later, as I was engaging in this concept of food and looking at how it affected cultures, and I was a peer educator in college, I knew that when I hit the next step of my career, which was here at medical school, this is day number 1 in medical school, much stronger hairline, holding on to that bottle of water very tightly, not knowing what to expect. But I knew going in that all of my interests that I had built over the years around this concept of food and nutrition, I would have to put to the side because I had heard that doctors don't engage with this arena of food and nutrition. I hadn't seen any doctors doing it. It wasn't a common thing. And I knew that I wouldn't be able to incorporate, I would have to hide a part of myself. It's quite interesting because some of you may say, well, yeah, doctors do talk about this. Let me give you some data around this very important fact. In 1985, a groundbreaking report from the National Academies came out. This groundbreaking report brought together a bunch of leaders and researchers from around the country, and they said, hey, let's look at what's going on around nutrition education in the present age in our medical schools around the country. Are we preparing our current providers and our future providers on how we can engage this topic of malnutrition and diet-related disease more effectively? The conclusion came from the committee that there were a few things that were really important. And the committee said this, they said this in the report. The committee concluded that nutrition education programs in US medical schools are largely inadequate to meet the present and future demands of the medical profession. This is 1985. They said at a minimum, we need to have at least 25 to 30 hours in medical school training. 25 to 30 hours. This is 1985. So clearly, years later, things have gotten so much better. The most recent data, what we've seen is what? What we've seen is that the vast majority of medical schools fail to meet even the minimum number of hours of nutrition education. 71% of schools fail to meet the minimum number of hours. In fact, a third of these schools fail to meet even half of those number of hours. So we know in general that there's very limited education around food and nutrition in medical training. This is a disservice to patients and families. But you know what? This is just medical school. At the end of the day, we have other opportunities for training and for learning, right? What about residency? What about fellowship? What about when you're practicing provider? Well, what they say is the same thing. We don't feel prepared to engage this topic of food and nutrition with our patients and our families. We are asked about this all the time, but we don't feel equipped to be able to engage this topic. But at the same time, we're also asked about food and nutrition all the time. Families, patients, they ask us, hey, how can we use food or nutrition to improve our health? And of course, we have to say something. And all of us, to some degree, feel that we're experts around food and nutrition because why? We all have our lived experiences with eating and drinking. So as a result, whatever grandmother taught us, whatever we learned on a TV show or magazine, we end up sharing that information. But the whole idea of eat less and exercise more as the standard of practice cannot be where this movement stops. So in general, this is what we see. There's a gap in knowledge, there's a gap in education. But the question I have to ask you is, well, why is this so important? Why is it important that clinicians be better trained in this topic, in engaging this topic of food and nutrition? If I were sitting in front of you right now, I would ask you some questions. And the first question I typically ask you is, how many US adults, what percentage of US adults have at least one chronic condition? What percent of US adults have at least one chronic condition? I would pause you. You can throw it in the chat if you want, but I want you to think about it. What percent of US adults have at least one chronic condition? When I ask my students this question, they say 30%, 40%. The answer is 60%. 60% of US adults have at least one chronic condition. 40% have two or more chronic conditions. It does appear that the default of life is that we will all get chronic disease. When you hyper focus in on diet-related chronic conditions, let's ask those questions as well. Let's start off with hypertension. If we start off with hypertension and we ask how many US adults, one out of how many US adults have hypertension? The number may amaze you. You may say 1 in 8, 1 in 5. The number is actually 1 in 2. 1 in 2 US adults have hypertension. What about prediabetes and diabetes? When we look at that number, of course, that must be less, but the answer is actually 1 in 2. 1 in 2 US adults have prediabetes or diabetes, and many of us, as you all know the data, many of us don't even know that we have these conditions. The reality is, it does seem like the default of life is to have these conditions later on. What about overweight or obesity? We know the numbers are 3 out of 4 adults have overweight or obesity. This is what we see in the literature. We understand that these rates are incredibly high. We also understand that this is costing us a ton of money. What do we see? Well, what we know is that the Rockefeller Foundation did an analysis, and we're seeing that these conditions are costing us more than $1 trillion annually. This is taxing the healthcare system. If you look at a list of risk factors that lead to premature death, let's ask ourselves, what are the leading risk factors that lead to premature death? Well, when you sort of lay that out, this is the Global Burden of Disease study. What do we see? The leading risk factor, the number one leading risk factor is what? Poor diet, poor nutrition. The leading risk factor leading to premature death is a poor diet, is poor nutrition. So we see that these conditions are influencing health outcomes. They're increasing morbidity, they're increasing mortality. And the question is, what are we going to do about it? We understand the role of food and nutrition. Food and nutrition can play a role in improving health outcomes. We get it. We don't need to see more data to show us that food and nutrition can play an important role in improving health outcomes. But what are the facts? The facts are that the vast majority of our food intake is from ultra-processed foods. The facts are that about 1 in 10 adults consume enough fruits and vegetables. And for children, about 1 in 10 as well. The facts are that inflation is increasing. The costs of these foods are increasing. Facts are that families are trying to do the best that they can. Clinicians are trying to do the best that they can with educating with the tools that they have. But this is incredibly, incredibly hard. What we need to understand is that at the end of the day, we need a paradigm shift. as I mentioned before, leaning into move more and eat less cannot be the solution when we talk about educating and working alongside families around this country. So we need a more novel solution. But as I mentioned before, this is a really hard thing to do. For us, for many of us, eating is a deeply, deeply personal experience. When we talk about food, for many of us, food has been used as a tool for punishment. Food has been used as a tool to numb pain. Food has been used as a tool to bring our families together. I love what this study did, the Meaning of Food in Life questionnaire. The Meaning of Food in Life questionnaire looked at a number of people around the country and they said, hey, what does food mean to you? And there are many domains that came up because, again, food is a personalized experience. Number one, some people said food is a moral experience for me. Food is a right or wrong thing. Some of us said food is aesthetic to me, right? I don't like foods how they touch. Foods can never touch. Some of you are like that in the audience, right? Food can mean it's a look thing. For many of us, food is social, right? It brings us together. I cannot have social moments without having food involved. In fact, the food enhances, it amplifies those social moments. For many of us, food is sacred, it's spiritual. Food is the spiritual moment for us. And also for many of us, food is health. And if you want to understand this concept of food as medicine, we have to understand the multitude of roles that food plays in one's life. It matters the context. If we were talking about providing a nebulizer treatment, right, where you give inhaled steroids or inhaled medicine for an individual with asthma, I need to understand the context. If I'm an ER provider, I need to understand the context of your home. Do you have electricity in your home? Can you plug in this machine so that it works? If we are going to provide food as medicine, we have to understand the context in which food can play in the lifestyles of individuals, in families, in cultures, and traditions. We cannot forget about this important piece. We've talked a lot about the role of chronic conditions. We've talked a lot about the role of disease, but we have to ask ourselves the question, what do we do about it? Well, when we ask ourselves the questions, what do we do about it? What do we know? When you look at professional guidelines around the country, we've seen that all of these different professional guidelines and many more that deal with diet-related chronic conditions, one of the first things that they're encouraging providers to do is start with exercise and eating, right? Lifestyle and food. But guess what we do? We skip over that step because we don't really believe it's going to work. We don't believe that people are going to actually implement these things in their lives. We haven't studied the evidence. Is this thing really that powerful if I change the amount of salt in the diet? Is it really going to change blood pressure if I change the nutrient intake? What is that really going to do? I know these medications work, but is food really a tool that can improve one's health? This has been a disservice, and we need to fill that gap. I need to hyperemphasize right here. Food as medicine is more than just training the next generation or training current providers. We only have 15 minutes in that window. This is about a paradigm shift. This is about changing systems to recognize the role and bring food into the spotlight as a tool to improve health outcomes. Let's go back to my story. In the early 2000s, I was getting ready for my first summer of medical school. And for those of you who know, that first summer of medical school is very, very taxing. People tell you if you don't pick the right activity, you're never going to land in that dream job. You're never going to figure out your future. You have to pick the right thing. So, there's a little pressure with picking the right thing. I remember going into one of our Office of Student Opportunities in my medical school, and I sat down in the desk and they said, hey, what do you want to do over your first summer? I said, I don't know. I've been interested in sports all my life. What about sports medicine or maybe orthopedics? I'm not exactly sure, but you know what? Forget all those things. I have this interest in food and nutrition, but doctors don't really do work in food and nutrition, right? She looked at me. I looked at her. She said, I don't know. I said, I don't know either. So we did a primary literature review. We actually just went on Google. And on Google, we found something that was quite interesting. We found this new internship through the American Society for Nutrition. And this internship was called the Clinical Nutrition Internship Program. They selected 2 medical students around the country to work with one of 60 different, or to work with 60 different PhDs or MDs who are doing work in this space of food and nutrition. I was able to work with a researcher and a colleague up at Yale University named Dr. David Katz, and I saw the role of nutrition in research. I got to work with his research team and research lab. we worked in the community and worked in community settings. We were building out program design. I saw how food can be used as a tool in a variety of different ways, and this could be a career for me. So I was incredibly excited, and that charted the path for me to say, you know what, if I did this, it may have to look different. There may not be a lot of people that I would be able to follow, but I know that this is something I want to do because I truly believe in the power of food for communities. I came back to DC after this amazing summer, and I worked with some of my amazing mentors. Here are some of my amazing mentors here. These mentors have taught me the very essence of community health. They taught me how to stop, how to look, how to listen, how to appreciate the real experts in the room who happen to be the community members I was working alongside. They said, hey, you need to assume a posture of humility, recognizing that we don't need to take a top-down model as healthcare, but work alongside patients and families because, again, they are the true experts. One of my mentors, Miss Ruth Perot, the person in the blue, Miss Ruth Perot, she would remind me, never confuse the MD that you will attain in your title in the future with medical deity. Don't get it twisted, as the young people say. That is not your role. Your role is to have the honor and the privilege to work alongside patients and families. These mentors have been incredibly, incredibly important in my life. Ruth and Canary, they're in their 80s currently and still call me in to work with their community members around diabetes and hypertension. And it's such an honor to see them on the front lines doing this dynamic work. So these are some of the mentors that really influence the work that I ended up doing. I never would have imagined, but a few years later, I ended up here directing my own culinary medicine program. Now, culinary medicine, for those of you who don't know, as Dr. Helsher mentioned previously, is mixing the beautiful art of food and cooking with the science of nutrition and medicine. We're bringing these worlds together and we're getting in the lab being the kitchen space. And we would be in this space and we would train medical students, faculty, staff, other students as well, community members on the power of food and nutrition for their own health. But not only that, how do you then talk about it with others as well? This was something I had been advocating for years. And this was an opportunity that I couldn't pass up. And if we pause for a second and understand the most important thing, if you look at my onion cutting skills, you can see just how great I had become in cutting those onions. It was phenomenal. But to be honest, one of the things that I had advocated for years was this great opportunity, and I really enjoyed it. And I never would have imagined a few years later I would end up here at Elevance Health. I was asked to apply for this position, this amazing position at Elevance Health. Elevance Health, previously known as Anthem, it's a large payer that serves over 40 million members around the country. There are over 100 million lives that are engaged through Elevance Health. They have insurance in private, commercial insurance, in Medicaid and Medicare, and they were looking for an inaugural food as medicine director, someone who could lead the initiative building off of all the great work they've done in the past in this space. Elevance Health used to be known as Anthem, as I mentioned, and they were already doing work in this space, but they wanted to bring the worlds together. And to be able to do this at scale and bring this work in to real population health work that we've been doing for years on the ground was something that I was so excited about and got a chance to understand, hey, this company was serious about this movement. So I applied for this position and I ended up getting this amazing, unique position where I've been able to sort of redesign the narrative around food as medicine from this large payer space and bringing in a new jargon that recognizes the patient-centric nature of what we are doing. So this has been a beautiful opportunity that I've been so honored to do over this last year plus. Now, people often ask this concept of food as medicine, can you define it for us? How do you define food as medicine? Well, the way we define food as medicine at Elevance Health is simply this. These are strategies or interventions that are working alongside healthcare, that are giving access to high quality, nutritious foods, focused primarily on three things. How do we prevent? How do we manage? And how do we treat disease? Better yet, how do we even put diseases into remission? How do we use food as an authentic tool to work alongside healthcare to prevent, to manage, to treat disease? Under the umbrella of food as medicine, we often think about things like food insecurity, nutrition insecurity, and diet-related chronic conditions. We spent a lot of time talking about diet-related conditions, so let's spend a little bit of time talking about food insecurity and nutrition insecurity. Let's start with food insecurity. So with food insecurity, the way we define food insecurity is when all members in a household don't have consistent access to enough food to live an active and healthy lifestyle. We know that food insecurity and hunger are technically different things. We know that food insecurity may lead into hunger, the individual sensation with the lack of food, that pain, that hurt, that pain, that discomfort when food is lacking. Food insecurity may lead into it, but it's not necessarily the same thing. As an anti-hunger advocate, I will use the word hunger because hunger resonates more with individuals more than food insecurity. People oftentimes don't know what I'm referring to. So I use the word hunger, which really resonates and drives home the point of what food insecurity leads into and what food insecurity can do. I love what Brenda N. Kennelly said from the New York Times. She said, a food insecure life means a life lived in fear of hunger. I know hunger is coming just around the corner. What do? It's just coming. The stress, the anxiety, the worry around that. Think about that. Think about how taxing that is. I know that with food insecurity, we also know that food insecurity is ubiquitous. Every single county in this country experiences food insecurity. It's also invisible. We cannot use those clinical tools that we've even learned in our clinical, in our training, whether that be anthropometric changes, weight gain or weight loss, or laboratory signs, or clinical exam findings. They're not reliable. They're not consistent. It is invisible. When we started screening years ago, and I started encouraging providers to do it, and they started seeing food insecurity, one of the things that they realized is that when they saw it, they couldn't unsee it. They had no idea that it was right in front of their faces. So this is a powerful thing to understand, the ubiquitous nature and the prevalent nature of food insecurity. What we've also started to talk about in healthcare is this concept of nutrition insecurity. And I need to emphasize that nutrition insecurity is not overcoming, it's not better than food insecurity, it's a complement to food insecurity. Nutrition insecurity is a term that's been brought forward in the States domestically in the last 2 or 3 years by the USDA, really hyper-emphasizing the focus on health equity and the quality of food. Are the foods that we are providing the right types of food to optimize health outcomes? Are they healthy, safe, affordable foods for individuals to be able to optimize their health and well-being? This is a critical piece of this food as medicine puzzle as well. Now, with food as medicine, we talked about food insecurity, we talked about nutrition insecurity, but we also need to talk about this concept of the food as medicine pyramid. Now, you all have seen this food as medicine pyramid before, but what is this? Let's break it down for those who don't know. There are 6 different approaches within food as medicine, or levers that we can use to address these challenges around food insecurity, nutrition insecurity, and diet-related disease. Number 1, what we call medically tailored meals. Medically tailored meals, pre-prepared meals designed by a chef and dietitian, designed to give you 50% or more of your calories for the day. They're delivered to their home and they're ready to heat and eat. They can be stored in the refrigerator or the freezer, right? These are designed to be nutritious, designed around certain diseases. Think about an individual who's post-discharge, who's just leaving the hospital, having difficulty getting to the kitchen or to getting to the grocery store. If they can't do that and they can't eat, malnutrition could be a leading risk factor to get them back in the hospital. Providing high quality food can be a simple tool used to reduce readmissions. The second one is here. It says medically tailored food packages, but we call it medically tailored groceries now. These are fruits and vegetables or produce and other items as well, whole grains, nuts, seeds, legumes, other items that are part of a healthy meal package that can be delivered to a family, that can be picked up at a grocery store, that you can give a grocery gift card, that you can go put some parameters on the gift card so families can purchase items that are designed with a dietitian to help to optimize their health around diabetes, hypertension, maternal health, whatever that may be. You can even think about a food pharmacy with an F, right? Where you can have in a clinical setting, where you can have high quality foods that families can come and get those foods to really provide nutritious meals for their family. Again, you want to think about this with family that can really help to create some sustainability, some longitudinal change with food as medicine, because you have to prepare those foods. Number 3, you think about produce prescriptions, right? Produce prescription initiatives are quite powerful. Why are they powerful? Because only 1 in 10 adults and 1 in 10 children consume enough fruits and veggies. So simply providing produce, whether fresh, whether frozen or canned, can be a great intervention to improve health outcomes. Number 4, federal nutrition security programs. What are these? SNAP, WIC, school meals, the list goes on and on. These programs are evidence-based to improve health outcomes, to decrease poverty, to decrease food insecurity. They decrease admissions, right? We know that they're effective, and we lean into them as a tool to support families as well. Number 5, population level healthy food policies and programs. We want to recognize our local community organizations, how they're anchored around food as medicine. Our local CBOs, community-based organizations, have been dynamic for years, and we don't want to eliminate them in this food as medicine movement. How do we work alongside our local food banks, our food pantries, our soup kitchens, our food policy councils? How do we work alongside amazing organizations on the ground to move this work forward? And last but not least, number 6, one of the things we often skip is personalized and empathetic nutrition counseling and education. How do we meet individuals where they are, providing high quality education and counseling, recognizing that we need to tailor the message for individuals? Healthy eating can look a variety of different ways, and we need to also recognize the importance of meeting individuals where they are. So this is an important piece. And when you look at this pyramid, most of the time people focus on the top 3 of the pyramid. These top 3 are medically tailored meals, medically tailored groceries, and produce prescription programs. With these top 3, you can see the price differential you have here. Medically tailored meals being the most expensive, and groceries and produce being a little cheaper. Again, there are differences in them, but all have been shown to be quite effective. The most research has been done, the most robust research rather, around medically tailored meals and the effectiveness of them. There's still a lot of questions we're asking in the literature, right? So we don't know all the answers, but we know enough from our standpoint, from the federal landscape standpoint, to know that we need to lean more into these interventions. What do we know about the data? Well, we know that we don't know all the time how long we should be doing them, what is the right dose, how much food we should be giving, what's the combination of foods we should be giving all the time. So we're learning more and more, and the more and more data, they're coming in as we speak to understand how we can continue to model this to better meet families where they are. So we talk a lot about these different conditions. We talk a lot about what we know about the data, but let's talk about some of the findings in the literature. We know that in the literature, we've seen that this can decrease ED visits, decrease hospital readmissions, improving dietary intake, stabilize blood pressure and A1Cs, a diabetes measure, stabilize mental health risk, decrease food insecurity. The list goes on and on and on. But one of the questions we need to ask ourselves is, where is all this momentum coming from in this food as medicine movement? Well, there are a lot of places that we know. In the first place, I don't like to emphasize, but one of the first places is COVID-19. We saw the long lines in the food banks, the long lines in the soup kitchens. We saw, SNAP rates increasing. We saw that people were dying at higher rates. We saw morbidity increasing, mortality, as I mentioned, increasing as well. And people said, what do we do about this? It brought a spotlight to food as medicine. We know in September of 2022, there was the inaugural, not the inaugural, the second conference. The first conference was 50 years prior, but the first conference in 50 years, the White House Conference on Hunger, Nutrition, and Health. And this also brought a spotlight to hunger, nutrition, and health, and recognized, hey, what can we do around this as a country? Over $8 billion in commitments were made from a multitude of organizations to move this work forward. And it was incredible. We know a lot of other groups have contributed, one being HHS. HHS had their own Food as Medicine Summit, where they really supported a number of different principles, including investing in the capacity of under-resourced community spaces. So we recognize there was a huge movement here as well. In fact, just this Monday, what did we notice? HHS launched a new Food as Medicine toolkit that you should check out. This Food as Medicine toolkit continued to add to this narrative. It showed you that there were so many national, federal partners invested in this space. Our team at Elevance Health was able to support this initiative as well, helping to really move forward the thought leadership in this space. At the end of the day, there's been a lot in this space. But I have to say, when I look around the room, I see something. There's an elephant in the room. What we've talked a lot about is our friends, our adults. And I have nothing against adults. I love adults. My best friends are adults. You all are adults, and I love you all as well. But, and I should say, I get the focus. I get the focus in food as medicine. I understand why we need to focus so much in adults. Why? Because adults carry the majority of costs in healthcare. I get it. Adults they carry the greatest disease burden. In addition, adults carry the greatest risk for the healthcare system. So I get the focus on adults. But you know what? I have a provocative question. What about the next generation? If we skip a focus on the next generation, we're going to continue the cycle of poor health outcomes. We miss out on an opportunity to transform health outcomes for households, to transform health outcomes for the communities as a whole. Let's not forget about the next generation. As a practicing provider, one of the things that I've gotten a chance to do for many, many years is incorporate food and nutrition into the education of my families, engaging in food insecurity screening, engaging in connecting my families to meaningful resources, engaging in connecting my families to registered dietitians and RD supports, because you know what? One of the goals of food as medicine is not to train MDs to become RDs. RDs are incredibly important in what they do. We can never do what they do, but we can work alongside them more effectively. We can work alongside other community inputs more effectively. And that's what it's about, changing systems. As a pediatrician, I got a chance to do this time in and time out, and I still get a chance to do it. And it's an honor and a privilege, but it hasn't always been that way. I want to tell you a story. I think back, way back, to the time when I was in pediatric residency. I remember being in pediatric residency. I remember being in my continuity clinic. Every week I would get a chance to see families. I remember being in clinic, and there was a beautiful family like the family you see here in front of you today. And they had a 4-month-old child, and they said, "Hey, Dr. Kofi, we're back here to see you again. Our baby's now 4 months. We're getting ready. The baby's almost 6 months. We're getting ready to start solid foods." How do we do that? How do we introduce solid foods? How do we get this child to expand their palate, to be excited about eating all these foods? And they smiled at me, and I smiled right back at them. I looked around the room, and I realized I was by myself. I ran out the room and grabbed my attending doctor, who, of course, the attendings know everything. I brought them in the room, and what the attending ended up telling that family wasn't helpful at all. And I was like, oh, I thought they were going to give them this groundbreaking answer. But this family left feeling like we don't really know what to do. And I realized right there that we were shortchanging this family. But you know what? I contacted my colleagues around the country who are also in residency programs. I said, hey, are you learning about how to do solid food introduction? Do you know anything about that? Are you thinking about that at all? And they said, no, we have no idea. And I realized right then that as a system, we were failing this next generation. We missed out on an opportunity with these growing children where their brains are rapidly developing to influence their growth and development, to affect their permanent changes in their brain with the foods that they were consuming, to affect their palate and the foods that they would eat in the future, and to save this family a ton of money by not having to be a short order chef to prepare these fish sticks for this child and everybody else eat everything else. At the end of the day, what are we doing about this? That's just in those first 1,000 days. But what about later on? When we don't incorporate and think about children, we're missing out on opportunities to do a few things: to prevent, to manage, to treat chronic diseases, to improve learning and academic achievement, to support brain development, to deter picky eating and expand the palate, to support growth and development, to support immune system, and even to support mental health. When we don't do this the right way, we're missing out on a huge opportunity to influence the next generation. What I want you all to think about right now is that with food as medicine, the whole household matters. We can't just focus on adults. What do I mean by that? Well, I'll start here. For us at Elevance Health, food as medicine starts with this concept of whole health. What do I mean by that? Well, we understand that within those 4 walls of clinical settings, where I see patients one-on-one, at the end of the day, it's not the leading risk factor that determines their future health outcomes. The leading risk factors are these other factors, these non-medical determinants or drivers of health that occur outside of the 4 walls of clinical settings. These factors greatly influence the health outcomes for our members, where individuals play, where they pray, where they work, where they sleep. These factors are huge. Food as medicine is a double click within this concept of whole health. When we think about one of the factors, one of them in particular being food insecurity. What do we understand about food insecurity? Well, one of the stories I would like to share with you is when I first started looking at COVID-19, I thought it was interesting. I used to describe COVID as the great equalizer. I felt like when I looked around the world, all these people were being affected. I heard about Tom Hanks and prime ministers and some of my community members, and I thought everybody was being affected equally. But the reality is, as I gazed more and more into COVID, I realized it wasn't the great equalizer. In fact, it was the great magnifier, magnifying inequities that had existed for far too long. When you look here at the data, we knew that there are already inequities around food insecurity amongst races and ethnicities. What did we see? Well, when you see these disparities, these inequities, what you notice is that when COVID hit in those first few months, all households increased in food insecurity rates, but some households increased more than others. Again, amplifying, magnifying what was happening. We needed to be able to see that, and we said, okay, now what do we do about it? It started being brought into the limelight. We know that the recent data around food insecurity that came out about 2 weeks ago in September showed us an interesting trend. In the last 20 years, what did we notice? Whenever we have a recession, we see a spike in food insecurity rates. This is households with children. We see a spike between 2007 2009. We thought we were going to see an even greater spike during in the early COVID years. We did see a spike in children, households with children, but not in all households. But households with children, we did see a spike. And then things got better with all of the amazing programs going on. But as some of the programs were starting to move away, we saw this increase in food insecurity rates. And most recently, our numbers are the highest they've been in the last 10 years, right? 1 in 6 households with children are experiencing hunger, as compared to 1 in 7 of all households. So we know that households with children have higher rates of food insecurity. We also need to understand the lived experiences, which are unique for children or for households with children. And what are those lived experiences? The way I describe it is simply like this. When a family has a sudden financial hardship, it sets off a cascade of coping mechanisms where food ends up being the first thing that families try to buffer. Because why? That food budget is so flexible, it's so fungible. And also, food insecurity doesn't travel by itself. So you'll see oftentimes other social drivers of health go along with it as well. So what do I mean by that? So when you think about this, the first step that families often describe to me is this concept of food anxiety, a constant preoccupation, perseveration with where one's next meal is going to come from, a worry, a decrease of one's cognitive bandwidth. The ability to shift and focus on many things becomes hindered because of that palpable toxic stress for families. The next thing families do is try to sort of do trade-offs. Should I get heat or should I get food, or should I eat? Should I get heat or should I get medications or should I get food? Right? So the other thing families start to do is changing the quality of food. And I call this the monotony of the diet. The diet becomes very simplistic, very monotonous. Families get the same foods over and over and over again. Why? Because they don't want to waste foods, right? So they want to get foods that end up being cost effective, that end up being cheaper for them, easier to access. And guess what? Foods that end up oftentimes being more ultra processed, higher in sugar, higher in salt, higher in fat, end up being cheaper. And the body will oftentimes gravitate towards those foods in times of stress. It ends up acting as a release valve for the brain. So as the body gravitates towards those foods, we know that the families sometimes it doesn't actually improve their health as well. So the diet gets very simplistic. Are families going to get a lot of fruits and veggies? No, because those fruits and veggies aren't going to last. So when we in the clinic say eat more fruits and veggies, and we don't recognize the experiences of households, we miss meeting families where they are. And that's a critically important piece. After the quality of food drops, of course, the last thing that drops is the quantity of food. And who drops their quantity of food first? Adults. Adults love their children and other vulnerable caretaker or people in their home. And lastly, when children decrease their food intake, we're nowhere at the end of this spectrum. You may say to me, well, why does it matter? Children don't experience a decrease in food intake all the way to the end. But what do we see from the very beginning of this journey? When the temperature of stress, of anxiety, of worry starts to increase, it increases for every single person in this home. It increases the stress, the worry, the pressure on everybody in this home, and it leads to what we describe as this concept of toxic stress. And many of you say, that's not a toxic stress. It's never been seen in the literature. That's not true. It has been seen in the literature. And also, we just wrote a piece about this as well to really sort of add more to the literature as well. And I want to talk about toxic stress for a little bit of time. With toxic stress, we understand that stress is important. There are many different types of stress. There are positive stress, tolerable stress, toxic stress. Stress is important because it helps to build resilience. Positive stress, you have a sudden stressor, you have a cut, you have a wound, you have an injury, and your heart rate goes up, things get better. But what about if you have a sudden death in the family or a significant injury? Well, a tolerable stress is when you have this significant damage or something that increases your heart rate, increases your stress response, but you have a phenomenal team around you. You have somebody who can help you cope with those stressors that are going on in your life. What about a toxic stress? Let's say a significant death in the family, a significant stressor in the family. Cortisol starts to increase in the body, the stress hormone. And what happens when you don't have a supportive system around you? So you're having to deal with this on your own, and you're having to work through this on your own, and you don't have the tools. And what happens is it guns your system. The cortisol increases, the stress increase, and it literally feels like that stress is getting under your skin, into your brain, affecting how you think, affecting your behavior. For children in those first 1,000 days in particular, we know that their brains are incredibly plastic, they're flexible, they're fungible, and as things and chemical influences and hormone influences affects their brain, we know it affects the permanent architecture of their brain. We know that these stress hormones can transform the architecture of their brain permanently. What do we see? And I don't want to get into the weeds here. I know I have some neuroscientists on the phone, so don't call me out. But I want to call out 3 different parts of the brain: the prefrontal cortex, the amygdala, and the hippocampus. So let's start off with the amygdala. This is the center for fear, the center for emotion. The hippocampus, the center for memories and emotion. This inhibits the stress response, while the amygdala activates the stress response. And the prefrontal cortex, this really helps with top-down executive function. Helps to control impulse control, right? Helps us with decision making and cognitive bandwidth. So what happens as a result when you cannot turn off your engine? When you cannot turn off, you cannot let go of your gas. Well, you increase your stress hormone, and the amygdala starts to hypertrophy or increase in size, permanently altering its shape. Well, if you can't turn off the stress response, what happens? The hippocampus and the prefrontal cortex start to decrease in size and start to atrophy. They start to shrink. So what happens for this child as they're growing? Okay, they have experiences that feel like PTSD. Somebody is crossing them and they're in the car and they cross in front of their car as they get older and they go from 0 to 100 and you're like, what? Why such a big deal? It's just crossing in front of their car. Well, what has happened inside their brain? It doesn't allow them to cope with future stress very well as well. So we blame this child and we're not realizing the toxic stress environment. It affects their learning, their memory, their executive function, their ability to focus in the classroom. All of these things are affected. What can be done to better support children in households using FAM? I don't have much time left, so let me land the plane. There are a lot of things that I want you to focus on, but our team created sort of a life course of a child focus, right? Pregnancy, infants, toddlers, school age, adolescents, and all of these programs can be quite beneficial. Meals, groceries, produce prescriptions can affect that whole period. SNAP, that whole period. WIC, women, pregnant women, infants 0 to 12 months, and children up to the age of 5, right? So from pregnancy to the age of 5. When pregnancy all the way to 5, when 5 starts, typically that's school age. So from 5 all the way to 18, adolescence, that's when school meals begin. Some states, you can start school earlier, pre-K3 or pre-K4. So you may see it started earlier, but typically school breakfast or lunch is starting in that period of time during school age. Summer meal programs can start from 0 all the way to 18. We know that the new summer EBT programs approved in some states go from school age all the way to 18 as well. What about child and adult care food programs? Daycare meals are for the daycare ages, and then for after school meals, that can happen during school meals as well, right? So you can see all these different tools. Population community level policies and programs, again, that whole period, and nutrition education and counseling during that whole period as well. There are a few salient points I want to get across today. Number 1, food as medicine in children deserves to be part of the national dialogue. Food as medicine with children has been lower on the priority list, but it has great potential. So we have to not forget that. The majority of food as medicine pediatric research is underpowered and more exploratory, so we need to build that research. Food as medicine with children has likely shown most impact in prevention of disease more than treatment of disease thus far, and also in addressing food and nutrition insecurity. We haven't seen a lot around improving cost effectiveness, savings, ER visits, hospitalizations, but it doesn't mean we shouldn't study it more. Federal nutrition programs are incredibly important with food as medicine. In fact, some would say the oldest food as medicine program is WIC. And they have a proven track record of success as well. Let's not forget about them. Federal nutrition programs, produce prescriptions, medically tailored groceries, and nutrition education have built the greatest evidence base, more than medically tailored meals. And last but not least, we have to think about food as medicine in children. Maybe a first step is thinking about household solutions. Because if you don't focus on the household and only give food to the adult, think about what happens if that household is experiencing food insecurity. That food is not going to go to that adult. That adult is not going to see the benefits. They're going to give it to the other vulnerable members in their home. So that's what I want you all to think about. I have a case study that I tied in here. I'm just going to run through it just so you can see practically what this looks like. Practically, in 2015, the AAP, American Academy of Pediatrics, said we should screen and intervene to address food insecurity more effectively. So what we began to do in 2016, I was asked to lead a movement at my home institution, Children's National, to start to screen and intervene in all of our clinics. And that was an amazing, amazing opportunity for me to do. And it gave me a chance to figure out a solution. What I'll tell you we didn't do is start with giving kale quinoa bowls to everybody, because we recognize that this is not meeting families where they are. Ellen Satter put a great pyramid up that overlays Maslow's hierarchy with food insecurity, and it showed that the first step for families is not giving novel foods that their palate is not used to, but making sure they have enough food, providing security, and walking with them on that journey towards improved health. So we have to start with them. What I started with is even better, was a piece of paper. Giving that piece of paper, which was beautiful. But what happened with that piece of paper? It didn't even make it into the trash can because it wasn't meaningful for families. Providers said, you're making me screen universally for food insecurity, and I don't even have a meaningful solution. I don't want to do this anymore. Families said, I'm sharing this vulnerable thing with you, and it's hard for me to share this, and you're just giving me this piece of paper? Is that all? So we realized we had to do better. So we looked in strategies that were community clinical related. We saw community clinical partnerships being designed around the country where families were in the center of the movement, where health equity was at the apex. And we said, what would it look like to partner with our colleagues around our local community? The YMCA, the American Heart Association, and ourselves at Children's National created a partnership called FLIP, the Family Lifestyle Program, which was focused on healthy families, healthy communities. And what did we do? We brought together a multidisciplinary team, and we started getting funding from the local Department of Health and from local funders and from national funders to move this work forward. We got a community advisory board to oversee the work we were doing. And also, we started to use food as medicine. We didn't know about food as medicine at the time, but we were using Connecting Families with Federal Nutrition programs, local programs as well. We were doing produce prescriptions. We were doing our local YMCA and American Heart were leading community cooking classes. And we developed a produce prescription initiative, delivering local produce from local farmers, from a local food hub that we partnered with, to our families. We partner with community cooking classes. And over the course of 6 to 12 months, we're delivering this high quality food to families. And we saw something quite interesting. Families said, hey, for the new ones, there was no better situation for me to use them. I didn't have to necessarily pay for them. And if we didn't like them, we knew to never buy them again. And if we did like them, we got to add it into our repertoire. It allowed me to see what my son does like and what he doesn't without me spending money on buying it. Sometimes you're afraid to try new things because it's like, if I buy this and no one likes it, it's money that I wasted. We're used to eating the same foods and fruits and vegetables over and over again. This broadened our horizons. We saw food as medicine be used as a tool to improve food insecurity, to increase diet diversity, and improve diet quality in families who experience food insecurity and diet-related chronic conditions. And we knew we were onto something. I want to leave you with this. I'm sorry to rush through this, but we have to develop and test robust measures in this space if you're going to advocate for children and families. We have to conduct more high quality, robust research in this space as well. We have to tap into novel feedback, get the stories of families, not just quantitative data, but qualitative data as well. We have to consider a variety of different conditions and diseases, not just BMIs and obesity, which we so hyper-focus on, but other conditions as well. We have to incorporate and partner and align with federal nutrition programs and our community-based organizations, which can help with sustainability and the infrastructure. And last but not least, we have to advocate. We have to advocate. We have to advocate. We have to lean into education. We have to lean into research. We have to lean into local policy to make sure we're transforming health systems, for the next generation. I want to thank you for your time, and I want to leave the door open for Q&A with no time left. I'm so sorry, but I hope that was helpful for everybody.
Well, actually, Dr. Essel, if you don't mind hanging around for 5 or 10 minutes, we can extend it. I realize that several of you will have to leave, but this will be recorded and archived. So if you want to listen to the questions later, you'll be able to access them. But you've got a lot of kudos and lots of questions. So a few that I'll pick out. I don't think we can get to all of them because there's so many, but someone had asked about what is the difference between culinary medicine and nutrition?
Great question. So one of the things that's interesting about culinary medicine is I want you to think about sort of the language of nutrition, right? And of course, it means different things to different people. But when I talk nutrition to families, one of the things that I do is I say, hey, you need to have enough B12, vitamin D, calcium. But the reality is families don't eat nutrients, families eat food. So when we use the language of food, it's transformative and it meets families where they are. And sometimes it's an easier tool for them to adapt. So culinary medicine is a practical way of engaging with nutrition, but through a food lens to empower and align with families and make sure that they are having the tools that they need to move their health in the right direction.
Yeah, yes, I wholeheartedly agree with you. Really nice. So the next question I have are, what are the first steps to incorporate the food as medicine into population health and the care of patients if we are not yet doing it?
Great question. So I think one of the first places to start is simply by starting by incorporating food insecurity screening, right? Food insecurity is not the whole of food as medicine, right? We think about food insecurity, nutrition insecurity, and diet-related chronic conditions, but food insecurity is a great place to start to think about non-medical drivers of health, right? And what do I mean by that? Well, we recognize that it's prevalent. We recognize that once you start to see it, it's hard to unsee it. And we recognize that we have tools in place that we can use to engage and address it that are effective, that are meaningful, that are powerful in meeting families where they are. So I would simply say, identify champions in your local clinical settings, your local health systems. Try to figure out how you can make it a part of the dialogue in your health system. Try to figure out how you can incorporate a screening tool. There are many different screening tools that you can incorporate, whether a comprehensive screening tool looking at a lot of different non-medical drivers of health, or even just looking at food insecurity, a tool like the Hunger Vital Sign, a validated 2-question screener that's the most common tool used around the country to identify at-risk status for food insecurity. You can start by screening even a small population and identify if they're at risk for food insecurity. If they're at risk, then you can figure out what you can then connect them to. Don't do this step by step. Do this where you create the system first, identify what you're going to connect them to. Don't start screening and then you figure out your rates are high and then try to connect them to something. Because why? We know that this can be a hardship for some families. Even in children or adults, sometimes they've shared in the national data, I don't want to share if I'm experiencing food insecurity, because what if you think I'm neglectful towards my child and you call Child Protective Services and they take my child away? I'm not being neglectful. I'm doing the best that I can. Are we creating a safe space for our families is critically important. So making sure that if you're going to have families share this hardship, make sure you have tools in place to connect them to. Creating a food as medicine system, whether you're working with your local food bank, some of your local food pantries, that's a great way to start, but also thinking about other ways, maybe starting with some philanthropy dollars, working with your local health systems to figure out maybe your local payers as well, to figure out ways that you can create seamless integrations into larger programs as well to optimize the health for families as well. Those are some simple ways that I would encourage you to do this. With screening, make sure you screen universally. Don't screen based on your own feelings, right? Because what ends up happening is we lean into our biases, right? Oh, this family looks like this, or they're wearing this, or they're doing this. No. It's ubiquitous. A lot of my families who are experiencing food insecurity, in fact, they wear the newest clothes. They bring the newest things because they want to put on that front of dignity, of humanity. They want to be rather recognized for their humanity and be provided with dignity. So at the end of the day, if I am calling them out for this hardship, it doesn't feel good. So I want to recognize them as human beings first. and recognize that food insecurity is ubiquitous. It happens to many families. And what can we do to be supportive and work alongside you to connect you to meaningful resources that are meaningful for you? I think that's important as well. Sorry, last thing I'll say, just because a family has food insecurity doesn't mean they want your resources. And just because a family doesn't have food insecurity doesn't mean they don't need those resources as well. So making sure you create systems that can be supportive, even if families don't want to voice their challenges, and also make sure you ask that question, hey, would resources be beneficial? Are you interested in resources as well? That's another piece. I gave you a crash course just now, maybe too much information, but happy to talk offline if you want to know more as well.
No, that was an excellent answer. And I think it covered a lot of different things, all the way from bias to accessibility of resources, not doing screening without having a follow-up for it. I did want to point out that here in Texas, the Texas Pediatrics Society has been very active in encouraging screening, universal screening for food insecurity. So kind of following up on that.
Fantastic.
So I have another question. I have a lot more. We won't get to all of them today, unfortunately. But this one says, my stepdaughter gets WIC and food stamps for her 2 children, 5 and 2 years old. Her children are picky and don't like to eat healthy foods. They want French fries and chicken nuggets. What can we do?
Whew. That's a great question. Let's put on the pediatrician hat. So first and foremost, let's call out WIC. One of the things people don't know about WIC is that phenomenal program. More than 50% of children who are born in this country start off using the WIC program. At the age of 1, there's a significant drop off in WIC. But what we've seen is that there's a new benefit. It's not new, but it's been bolstered. It's the cash value benefit, providing $26 plus per month that families are able to use on a card that serves as a produce prescription initiative itself. Right? Families are able to use that and buy produce at the store. Depending on how many children you have between the age of 1 and 4, right? When you hit 5, you're out of WIC. But depending on how many people you have, you're able to sort of double up and triple up those dollars if need be. That can be a great tool to improve purchasing power for families and purchase the items that they've been looking for. They want to buy those foods. It's just really hard with the cost of food and prices, and also their palates being hijacked by a lot of these other foods. So I think that's something to think about. Now, I would start with starting early. Did you know that in the womb, around the 2nd to 3rd trimester, that the fetus is starting to taste and smell foods? Their palate is starting to be adapted early on. So we can start to be strategic in those early periods of time as well. Let's not blame ourselves, because this is not about blame, but this is just another tool we can use when we're talking to other people. Did you know that the breast milk will have flavors of food and nutrients as well that individuals could start to eat as well? So that infant is starting to taste that if you choose to breastfeed. If you're using formula, there's flavors in the formula as well that infant will start to get used to. Did you know that, hey, when you start to introduce solid foods, you can be more diverse in your introduction of solid foods, right? So a lot of times with solid foods, we start off with foods that, well, most people will say, I'll start off with rice cereal, right? We don't have to start off with rice cereal. We don't need to start off with rice cereal or cereal at all. It's one of the things you can consider. But in general, it's really important to diversify the foods in that first in the 6 months, right? So typically we recommend from 6 months to 12 months, giving a variety of different foods. It can take from 8 to 15 times of trying a food before that child or that infant may adapt. And if families are experiencing food insecurity, what I often say is, for some of them, they hear 8 to 15, you may hear 8 to 15, but they hear 7 to 14 times. 7 to 14 times of what? Of waste, right? So this is a concern for them. It increases anxiety. So they will lean towards foods that their child may like and have a smile on their face. And when you give sugar, salt, when you give fat, the body has a natural predilection for those foods. So when you give those foods, the child brightens up. When you give fruit, the child brightens up. When you give juice, the child brightens up. So the natural subconscious says to a parent, I need to give more of these foods. I'm a good parent. I give more of these foods. When I gave that bitter umami flavor, those vegetables, that bitter flavor, they made a face. So that means they don't like it. They're just like me. I don't like broccoli either. So let me never give them that again. So what ends up happening is their palate starts to be adapted for only sweet foods. Now you're adding more salt to the food. And so we're starting to get behind in that battle. We can start early and diversify the palate, giving the right foods and really expand that palate on. So that's another strategy you can do early on. Now we're talking about young children. Let's talk about some strategies for young children. So a few things that I recommend in clinic is start with this. Number one, appreciate the role of hunger. A lot of times we're giving snacks all throughout the day, snack, 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 snack. So if you're giving a lot of snacks, a child never gets to develop a sense of hunger. So when it's time for a meal, they're like, you know what? I've already eaten. I'm not going to eat all of this. Make sure you have at least a 3 to 4 hour period between meals, between a snack and a meal. So let's say 3 hours, just in case, right? So you have some time for that child to bring up, to build that hunger, so they actually go into that meal with an increased desire for that food. That's a big thing. Number two, make sure you're modeling the behavior you want to see, right? Let's not penalize our children, or let's not penalize or look at food and create this maladaptive relationship with food. Oh, I have to eat my broccoli again. No, no, no. Enjoy it. Show you enjoy it. Show that modeling of enjoying these different foods, giving these foods that you know you're enjoying as well. This is something that can help as well. Decreasing the sugary drinks, right? So you don't have to eliminate them completely, right? You're taking steps. But if you decrease them, what you'll notice is that their palate may start to change to where they don't need to have as much sugar all the time. In my clinic, we talk about decreasing sugary drinks, and then some of my patients or the families will say, well, Dr. Kofi, then what are we going to drink with some flavor in it, right? I have to have flavor, right? Because their palates are already hijacked, right? Their brains are already hijacked. I need to have sugar. I need to have sweet. So again, decreasing that can change that sweet stat, can change that salt stat, so that it's not as necessary to have those things. Remembering to introduce food multiple times, remembering to give foods in different ways, right? Because sometimes we just give those Brussels sprouts in the boiled way, and nobody likes it boiled only, right? So you add some flavor, add some salt, some spices, right? Change it up, add it in different ways. That's critically important. Decreasing the sugary drinks multiple times, modeling good behavior or the behaviors you want to see, not penalizing bad behaviors, not looking at foods as good or bad, but recognizing that there's a spectrum here. And you want to encourage the behaviors you want to see, not giving up, and making sure you keep this in mind. At your state, you talk with your pediatrician. If this is bad enough, sometimes they need a little bit of feeding therapy, right? Different strategies that they can use to help them with engaging foods in a way that can diversify their palate as well. I got a lot of other ideas, but those are some of the ways that I recommend to families as well.
Yeah, when I used to work with school meals, one of the things we knew is if you change them at the beginning of the school year, everybody comes in, they might complain a little bit for the first few weeks, but after a few weeks, they're used to it. That's the food that's available and they'll eat it, you know? So that's a great time to kind of make changes, at least in the school system, with new foods and introduce them. So, well, I know we've gone over a little bit, so I just wanted to thank Dr. Essel again. This has been an excellent talk, and I can't tell you all these comments that we have about how inspiring this is and what an excellent speaker you are. So we'll share those with you. There are some questions we didn't get to because there are a lot of questions. So we'll follow up and see if we can get answers for you for those questions. So we really appreciate you asking them. So I wanted to just thank all of our team, Dr. Sharma, for getting this lecture together, putting it together, and for all of you for sticking around for a few extra minutes. As I mentioned before, the talk itself and the slides will be archived on our website, and you'll receive a follow-up message about the lecture, so you'll be able to access those later. So thanks again for a terrific presentation, Dr. Essel. And we look forward on following up. As someone who really works with children and adolescents, this is really very close to my heart. So I can't thank you enough for this.
Thank you all for having me.
Y'all have a great rest of today, and we'll see you online. Take care. Bye-bye.